Hi, you are in the ladies' room with Dr. Donica, the only public ladies' room you can enter anytime without ever waiting online. I'm your host, Dr. Donica Moore. We'll be having real conversations with real women about really intimate issues. They may be embarrassing, sad, or funny, but they will always be interesting and informative. You know, like the best conversations you've had in ladies' rooms with your best friends, or total strangers and a physician. Please join us. Hello, and welcome to another exciting episode of In the Ladies' Room with Dr. Donica. Now, most women have heard of the F word, and that is fibroids, and most women will have them. So let's talk today about fibroid facts. First of all, fibroids are the most common type of non-cancerous tumors in women. But just because they aren't cancer doesn't mean that they are benign. They can be asymptomatic, but more often they cause a wide range of physical symptoms, including heavy menstrual bleeding and an overall reduced quality of life. Statistically, uterine fibroids occur in more than 80% of African American women and more than 70% of Caucasian women by the time they're 50 years old, which is looking younger and younger to me. Fibroids are also the leading reason for hysterectomy performed in the United States. Now, my guest today, Dr. Veronica Gilespie-Bell, knows a lot about fibroids, both personally and professionally. She's a practicing OB-GYN and section head of women's services at Ochsner Kenner in New Orleans. She's the medical director of programs within the Louisiana Department of Health, as well as an associate professor and director of the Center for Minimally Invasive Treatment of Fibroids. She earned her medical degree from Meharry Medical College and completed a residency training at Ochsner Health System. She also earned a Master of Applied Science in Patient Safety and Healthcare Quality from the Johns Hopkins Bloomberg School of Public Health, and she's received certification in diversity and inclusion from Cornell University. Dr. Gillespie-Bell, you are a busy woman. Thank you for joining us in the ladies' room. I super appreciate it.
Thank you for having me.
Now, of course, we have to start with the fact that we're taping this during the huge relapse in the Delta variant of the coronavirus. So first, I want to just ask you, how are you and your family doing with respect to COVID?
Thank you so much for that. We are all well. Everybody that can be vaccinated is vaccinated. Thank you. And so happy for that. And fortunately, we have not had any setbacks from COVID in our family, but I am definitely seeing it across the state and across our health system as we're starting to decrease number of beds and having to delay surgeries. And that is particularly affecting my patients that have fibroids.
Right, because fibroid surgery, if you ask anyone except the patient, fibroid surgery is considered unnecessary or not essential or not emergent. And fun fact that you don't know about me is that my senior thesis topic when I was in college 100 years ago was the unnecessary surgery debate with respect to hysterectomy. So this is one of my pet peeve topics.
Oh, yeah.
And something that I knew an awful lot about in 1981, but a lot has changed since 1981 with respect to fibroids. In fact, one of the misconceptions about fibroids is that a lot of women think the only treatment is surgery.
Yeah, so there are so many options available. And if I can take just a moment of privilege, Dr. Donica, the reason that I started down this pathway of fibroids and thinking about fibroid treatments, my mother was diagnosed with fibroids when I was in college at Xavier and had to have a hysterectomy. And I was like, what are fibroids? I've never heard of this. So the nerd in me started doing research and looking at treatment options. And back then, really the only option was surgery. And then there was a medication that you could take to shrink the fibroids in the uterus to do a more minimally invasive surgery, but not a lot of options out there. And so at that moment, I said, I'm going to find the cure for fibroids, which is a little unrealistic, but I do feel like I've been able to bring my career full circle in being able to investigate or being part of research studies to look at other options and being able to offer those other options to patients. And so you're right, there are non-surgical options that are available. And so for the listeners, patients and providers, definitely look into those options and think about it as we are having to change how we're managing based on the pandemic.
So not only are there a wide range of options available to women now that weren't available when your mother had her hysterectomy, we have a very different viewpoint on the surgical treatment of fibroids. We have a whole range of treatments. And before we get to that, though, I want you to tell us the rest of your story. So, of course, your mother had fibroids, which does give you an increased risk factor for having fibroids. And at what point were you diagnosed with fibroids?
Yeah, so I was in residency and starting to have some irregular cycles and heavy cycles. At that point, this is embarrassing to say, I didn't know that you weren't supposed to wear a tampon and a pad. So I didn't realize
as a GYN resident.
Yes, as I was matriculating, I realized that was not what most women do. And so at that time decided to just monitor because I was busy. I didn't have time to really deal with that. I definitely didn't have time for surgery. But then a few years later, my fibroids did become pretty large. I had one fibroid that was about 8 centimeters, and I know your viewers can't see me, but I'm a little petite woman, so eight centimeters. There's not a lot of space for 8 centimeters in my abdomen.
We usually talk about medical things, especially tumors. I don't know how this started, but we talk about them in sizes of fruit. So 8 centimeters is the size of what kind of food?
A cantaloupe.
Exactly.
Yes.
So we're talking, big.
Yeah. And so I did have a myomectomy to remove that fibroid, and it's 2 friends that I didn't know were there. They went away as well. And so,
okay, so
yeah,
let's stop because not everybody knows what a myomectomy is.
Thank you. That's true. That's
true. Tell everybody what a myomectomy is and tell people why you made that choice. As opposed to most women who decide to have a hysterectomy. You were how old?
Sure. So I was 33 at the time. I had not had children yet. And so wanted to preserve my fertility. And so I had a surgery to remove the fibroid.
Okay. So if you were, let's just hypothetically say, if you were 52, would you have made the same decision?
If you had asked me that at 33, I probably would have said no. Mm-hmm. But now at 43 and getting closer to 52, I would have still made that same decision. I was one that had the 1 large fibroid and the 2 small. Mm-hmm. And so I probably would have still made that same decision, although there are now the other procedures that I may have considered. I still would not have chosen to do a hysterectomy though.
Okay. Because?
Just because for me, I had just, again, that 1 fibroid. I knew that taking care of that was going to take care of the problem. At 52, the chance of having a recurrence of fibroids is very small. Mm-hmm. And I just would want to keep my girl parts. And patient autonomy is really important, and that shared decision making and how we decide what we're going to do.
Mm-hmm. So we have talked about fibroids in lots of other segments on this podcast. We did talk to a woman who was in her early 50s who did make a similar choice. She had many more than 1 fibroid, went in for elective surgery and had every disastrous outcome you could possibly imagine and left the hospital without a leg. She wound up having to have her leg amputated because of shock and blood clots and infection and all kinds of horrible things. Don't get too sad because she went on to become a Paralympian. But the reason she made that decision in her early 50s is because she had not yet had children. And her physician had not informed her that her odds of having children at that stage in her life, especially given the extent of her fibroids, was extremely, extremely small. But back to your case. So you were in residency, you had fibroids, you decided to have a myomectomy. Explain to people how a myomectomy is done.
So there are 2 big ways that we do myomectomies. One, and the way that I had it done, is through a C-section incision. That's kind of the easiest way to think of it, a little bikini cut, where we make an incision on the abdomen, go to where the uterus is, and make an incision over the uterus, take out that fibroid, and sew the uterus back together. The other way to do the procedure, which is a procedure that I do, is a robotic myomectomy. And so that's using the assistance of the robot to do a laparoscopic removal. And with that, there's less blood loss, less pain, and a shorter return to activity. At the time in the area where I practiced, I was the only one doing robotic myomectomies. And although I had a dream that I operated on myself, that's not reality. So
I think every OBGYN either has the dream of operating on yourself, and some would call it a dream, some call it a nightmare, or the nightmare of having to do your own C-section or deliver your own baby. That was my recurring nightmare for a few years before I had my first child. And actually, once I had my first child, that went away. So the idea, basically, very simply put, is that doing a myomectomy just removes the fibroid as opposed to using the whole uterus. I also want you to explain to women another really common misconception about hysterectomy. Many women use the term hysterectomy to refer to not just having their uterus removed, but also their ovaries. So talk to us about that and how we make the decision whether to leave the ovaries or take everything.
Yeah, that's a great point. Because I have a lot of patients that come in that they really do want a hysterectomy, but they tell me, I don't want to go into menopause. I don't want to have hot flashes and night sweats. So when we remove the uterus, we can remove just the uterus, the cervix, and leave the ovaries behind. And your ovaries are what provide your hormones. And so you don't always have to lose those ovaries and then have those menopausal symptoms at the time of hysterectomy. The way we make the decision, if you are under 50, it is recommended to keep your ovaries, because if you're under 50 and you have your ovaries removed and you don't go on hormone replacement, there's a higher risk of heart attack and stroke. And so the natural production of hormones is better at that age. Once you're over 50, 52, menopausal range, your ovaries are not producing a lot of hormone. And so it is okay at that point to remove them because they're pretty innocuous. They're not doing as much at that point. And that's really how we make the decision, with the addition of other individual factors, individual desires, family history, any risk for ovarian cancer, BRCA1/2 gene mutation positive, then that changes the decision.
So connect the dots for people too about when you're over 50, your risk for ovarian cancer greatly increases. And unfortunately, we don't have a really good screening test for ovarian cancer.
Right. And so the risk of ovarian cancer in general is relatively small, but if you don't have ovaries, it's zero. And so when you're over 50, your ovaries aren't really doing very much. And so it's not really there's no benefit to keeping them. And the risk is that you could possibly have develop ovarian cancer.
Right. And it's still the fourth leading cause of GYN cancer is
Correct.
ovarian cancer. And of course, like any cancer, if it's discovered early, it has a fairly high success rate as far as treatment. But most ovarian cancers, unfortunately, are not discovered till a later stage or stage 3. So what we did is we put the cart before the horse and we talked about surgery first, because that's most dramatic. And that's also what you experienced. Were you able to go on and have children after you had your myomectomy?
Yes, I was. I have a beautiful son who is now 8 years old. Yes, and had a great pregnancy. I did, as common when you have a myomectomy, I did have to have a C-section for delivery.
Okay, explain to people why that's a thing.
Sure. So the way I usually explain it to my patients, if you think about the uterus, when it's not been operated on, it stretches like a rubber band when you're in labor. After it's been operated on and it heals like Velcro. And if you can think about Velcro, there's only so much stretching you can do with Velcro before it pulls apart. And so if you've had a myomectomy, then the tissue is not as strong. And so you don't want those contractions of labor because it can cause the uterus to rupture.
And we say that for any uterine surgery. However, and in my day, we used to say that about if you had a previous C-section, you had to have another cesarean section. However, that thinking has changed. So talk to us a little bit about that.
Yeah, it has. The reason is when we do a C-section, for the most part, we do what's called a low transverse C-section. Now, not to be confused with the type of incision that we make on the skin, that doesn't have anything to do with it. It's the type of incision that we make on the uterus. And we make it usually in the lower uterine segment. And in labor, that part of the uterus actually balloons out. It doesn't contract. And so because of that, there's not a risk of uterine rupture if you were to have what we call a trial of labor after cesarean to try to have a vaginal birth after cesarean. So what matters is where the incision is on the uterus.
Right. And like anything in motherhood or anything in medicine, it all depends on everything. So of course, all of the things we're talking about are general discussions, and obviously any woman needs to talk about her own individual circumstances with her own doctor. The point of this conversation is to let women know what the possibilities are. So how does somebody know if they have fibroids?
So there are symptoms that are associated that as women, if you experience, you should talk to your doctor about. The main symptom that we see with fibroids is heavy menstrual bleeding. Now, and for your listeners, I usually ask my patients, are you using pads or tampons? How many you're using? How often are you changing? Because to ask the question, is your cycle heavy? Is only a cycle is only as heavy as your cycle is, right? So we try to quantify that in terms of products, or if you're using a Diva cup, how often you're emptying. But that's the main symptom. But you can
Or if
also
you're using
have
a tampon and a pad.
and a pad, i.e. me.
We've actually talked about heavy periods on this podcast, and I call them crime scene periods. You know,
Yes.
so you're using a pad and a tampon, and there's still blood on the sheets when you wake up, or there's blood on your panties, or you got there just in time.
Yes, yes, yes. And the other symptom we see is pelvic pressure, pelvic fullness, a lot of times urinary frequency because the fibroids are either pushing on the uterus or the fibroids themselves are pushing on the bladder. And so
So
we see those
define
other.
urinary frequency. How frequent is too frequent?
So there's not an exact scientific time, but if you find that you're going to the bathroom every hour or feeling like you constantly feel like you have to go to the bathroom to urinate, then that can be sometimes. I mean, there are other reasons to have urinary frequency, but that can be a sign if there's pressure on that bladder from the fibroids.
Other reasons to have urinary frequency, and all of them should be evaluated, especially if there's any urinary leakage at all.
Yes.
Except in the middle of aerobics class. When 30% of the women leave the room. What about sex?
Yeah, sometimes fibroids, especially when they start to get large, they can cause pain during intercourse for sure.
Okay. All right. So a woman recognizes she's having some funky symptoms. She should go to her doctor, preferably her OB-GYN. They have a conversation. Then what happens?
So generally after the conversation, there's a physical exam, the pelvic exam, which we're all familiar with and hate it, but we do a pelvic exam. And usually that's followed by imaging, either ultrasound, MRI, but something so we can actually look at the uterus and look to evaluate to see if fibroids are there.
But your first choice imaging would be ultrasound.
Correct.
Okay. So then you decide, you see the fibroids, you see whether there's one isolated fibroid, you see if there's many, have a look. Sometimes you need to do further testing or further imaging. But then you call the patient back and there's a conversation. How does that conversation go?
So when I have the conversation, we talk about as patients are coming in, their desires for future fertility, for uterine conservation, because that helps me to guide them through all of the treatment options. I am one to give patients all of the treatment options, the risks, the benefits, and then try to guide them to the best decision for them. Again, based on what their goals of treatment are, whether that be because of bleeding or pain, and also their goals for future fertility or uterine conservation. And there are many women now that are choosing to, as I would at 52, are choosing to conserve their uterus, even if they're not planning on future fertility. but understanding those goals, and then that helps to guide them through the treatment options.
So of course, symptoms are our primary concern, but size matters in this arena. Talk to me how size figures into this, and is there a special number that we look at?
So size matters and location matters as well. So, and I'm going to actually flip and talk about location first. So fibroids can either be located on the inside lining of the uterus, in the muscle wall, or on the outside uterus. Those that are on the inside, generally you have more bleeding because the uterus does not like it when things are on the inside lining that are not supposed to be there. And it responds by cramping and bleeding. And so those
And we see
fibroids.
that even with non-hormonal IUDs.
Correct.
We generally have more cramping and bleeding.
Correct, exactly. And so we think about that, the location, because that will relate to symptoms, but it also for treatment options. And then when we think about size and the number of fibroids, that also will determine what treatment option may be better, or what treatment option may not work as well. So for example, when I have patients that are wanting a myomectomy, for those patients, and again, that's having fibroids removed, for those patients, generally I've done an MRI. Ultrasound is good at saying you have fibroids or you don't have fibroids. It's not so good at saying how many or where. An MRI is better for that. And so once we get that MRI, if I see they have a fibroid that's greater than 10 centimeters or they have more than 10 fibroids, I don't usually recommend a robotic approach because it's just much harder to close the defect if the fibroid is that big. And if there's more than 10, then it's really hard to get them all. And so I usually, if they're thinking surgery, then I usually recommend an abdominal approach. So that's a time when size and location matters. Now, if they're having heavy menstrual bleeding and they're thinking a medication choice, for example, if they're thinking about something that's going to control the heavy menstrual bleeding, we do know that from the clinical trials with Orion, which is the first FDA-approved oral medication for treating fibroids, that the size and location did not matter in terms of the response rate. And so in that case, it doesn't matter as much. But it really just depends on, again, for women, what they're wanting for their goals for treatment.
So now Orion is a new medication. It was approved when recently?
It was last. I apologize, I don't remember the exact date, but it was last year that it was approved. It was right during the pandemic.
Yeah, everything in my mind is if it happened during the pandemic, it's recently. If it happened before the pandemic, then I remember when it happened.
Yes.
But everything in the pandemic is kind of a blur, and pretty amazing that things like drug approvals still happened in the pandemic that were totally unrelated to COVID. So kudos to the whole team who did that. But tell us how this works. Does this, this is a new tool. I love it when we have new options for women for anything, and not every option is for every person, obviously. But how does this work to control the bleeding?
So with Orion, it's a GnRH antagonist. So basically, GnRH is this hormone that's released from our brains that makes us release FSH and LH, that makes us release estrogen. And then our fibroids grow because of the exposure to estrogen that we naturally make. And so this medication blocks GnRH so that we have a decrease in estrogen production so that there's nothing feeding the fibroids, feeding the lining of the uterus. And that's really how it works to control heavy menstrual bleeding.
Which is basically how menopause works to control fibroids.
Exactly. So this medication, to some degree, you can think of it as a medical menopause, but it's reversible.
Okay. And can women still get pregnant if they're taking this?
So they can, but the plan would be that they should not. The recommendation is to be on a non-hormonal birth control while you're taking this medication.
Okay. Or else?
It's not necessarily an or else. It's the way that the clinical trials were done. The women in the trial had to, at that time, use 2 forms of a non-hormonal contraceptive. And so because the trials were done that way, we can extrapolate, but we don't really have clinical data to say exactly what happens if you're taking the medication and you become pregnant.
Got it. And can women safely become pregnant if they stop the medication for X amount of time?
Absolutely.
Okay. So we also have talked in the show about uterine artery embolization, which is another option. You want to talk to people about how that works and how that fits into our decision-making tree?
Sure. So uterine artery embolization is a procedure done by interventional radiologists, generally not done by gynecologists, but interventional radiologists. They go through either the artery in the wrist, the radial artery, or the femoral artery, which is an artery in the leg. And I think of them as like little plumbers, and they go through the artery to get to the uterine artery, and they put in polyvinyl beads. And these are usually absorbable, but they put those beads in and they block the uterine artery so you don't have as much blood flow going to the uterus, going to the fibroids. Now, the good part of that procedure is you can keep your uterus. It is effective at decreasing heavy menstrual bleeding. The downside is sometimes those polyvinyl beads can migrate and can affect the ovarian arteries, and so it makes it harder to ovulate. So we really recommend this option for women that are wanting to keep their uterus, but are not wanting to have future fertility, because that could be affected.
And are there other medications that are useful for fibroids?
So there,
Motrin and
so there are medications that we as doctors use for treating symptoms associated with fibroids. They don't really do anything for the fibroids. So for example, tranexamic acid or Lystata is a medication that controls heavy menstrual bleeding. It controls bleeding in general. It's used by orthopedic surgeons. We use it for postpartum hemorrhage. It just controls bleeding. And so if we have women that are having heavy periods, it is an option, but again, it does not do anything for the fibroids. It's not a hormonal based medication. We have our old standby of birth control pills. But we do know from clinical trials that birth control pills are not as effective in really controlling periods. They make cycles shorter usually, but they can still be irregular. And depending on the location of the fibroid, we already talked about those ones in the lining of the uterus. Women will go on to still have heavy bleeding even with the birth control pills.
Well, and explain, this is a little confusing because, we say estrogen feeds the fibroids, and we know estrogen's in birth control pills. How does that work then?
The estrogen and the progesterone that's in birth control pills is still not as much as we would naturally produce. So it does lower your normal hormone level. And there are different types of birth control pills. We have some of our low dose estrogen containing pills. So you have an even lower dose of estrogen than what you would naturally produce. And these birth control pills are lower than some of the other ones.
Right. And many women, we recommend birth control pills for heavy periods not associated with fibroids, because birth control pills generally decrease menstrual flow in most women, which is a really important point, I think, for most women to understand. What boggles my mind is how iron deficiency anemia is still so common in women who are menstruating, even in the United States. Certainly worldwide, this is a very big problem. But this just means a low blood count, and it's a common problem in up to like 25 or 30% of menstruating women. Easy to test, easy to treat, easy to prevent.
Yeah, I agree. And I think a lot of times doctors forget to check that blood count, even when women say they're having heavy bleeding. So I think that's one part of it. I think for women, we don't always come in saying, I'm really tired. And if we do, we explain it away because we all do 50 jobs and taking care of our families. And we feel that the fatigue is just because we're working and don't understand and put the correlate it with our periods. So I think it probably, you did say the statistics. I think it's higher. I think it's higher than that. We just underdiagnose it and undertreat it.
Okay, so we glossed over a little bit. We went from heavy bleeding to fatigue. Again, connect the dots for people. What are the symptoms of heavy bleeding, aside from the fact that you see the evidence? Aside from the crime scene, how does that make you feel?
Yeah, I think fatigue is the biggest symptom. Just really, really tired. I tell patients blood is life. And so when you're losing it, you have no life, no energy.
Excuse me, easy for me to say. Blood is also oxygen. All right, so blood literally carries the oxygen from one part of your body to the rest.
Yes. So just no energy to do anything. Sometimes women have something called pica, which is where they have cravings for unusual things. Usually it's ice, but I have patients that have craved baby powder, baking soda, laundry detergent, things that I have no idea from a pathophysiology standpoint why those are the things that you crave when you have that pica. But that's also a symptom of anemia, is having those very strange cravings. But the main symptom I see is just that fatigue. It's hard to climb stairs, hard to take long walks, hard to do activities with your kids or exercise or any of those things.
Headache,
Yes.
dizziness, lightheadedness, shortness of breath, paleness, looking pale.
Mhm.
So, especially, if your mother says, you're looking peaked, or you're looking pale, that's a pretty good diagnostic sign that it's time to see your doctor and get a blood test.
Yes.
What other complications other than anemia or low blood count and all of its intended symptoms do we see from women who are suffering from fibroids? We really didn't talk about probably one of the number one things, which really is pain.
Yes. So pain is a significant one. And we talked about location of fibroids, and the fibroids that are on the outside of the uterus tend to not interfere with periods quite as much. And so they tend to not get diagnosed until they're starting to press on other organs. So I've had several patients to come in with something called hydronephrosis, meaning the kidney is swollen because the fibroids have gotten so big that they start to press on a tube called the ureter, which is a tube that connects the kidney to the bladder. And when they press on that tube, then it causes the kidney to back up and to swell. I've had patients that have had the inability to urinate. They can't urinate at all because the fibroids are so big that they're pressing on the bladder in a way that they can't empty without elevating the uterus. Constipation, as we've already kind of mentioned that. And then just feeling that bloatedness, fullness, pressure, heaviness in your abdomen, all of those things.
Okay, sounds pretty depressing. And then, of course, in like a worst case scenario, we also have organ prolapse. So we actually did an episode once, believe it or not, we had a woman who was willing, we talk about all kinds of embarrassing things in the ladies' room, and she was willing to talk about how her constipation was so bad that she actually had rectal prolapse, where, in my mother's generation, they called that your kishkas are falling out, which is kind of a very good description of it. But what other organs can prolapse? And talk to me about what prolapse means.
Yeah, so prolapse is just that the tissue is either there's pressure from above, or the tissue that supports the pelvic organs is loose. Just an easy way to think about it.
Or both.
Or it can be both. And you can have prolapse of the bladder. You can have prolapse of the rectum, as you mentioned. You can have prolapse of the cervix. You can have prolapse of the uterus. Even if you've had a hysterectomy, you can have prolapse of the vagina.
Mm-hmm. Right. And very often women will come in and say, I feel like there's something in there that shouldn't be in there.
Yes. They usually say, I feel like something's falling out. And then I do their exam and I say, you're right, there is. But we can do something about it.
Right. Well, this is awesome. I could talk to you about this all day long. But in lieu of that, tell us where women should go first and foremost for more information if they're having any symptoms.
Yeah, so there is great information on the CDC website about fibroids. The White Dress Foundation has really great information, and it's a great patient advocacy group. On the AbbVie Orion website, there is great information there as well about fibroids in general and about some of the treatment options that we've discussed. There's a lot of really good information on several websites now, and a lot of really good blogs and groups that are discussing fibroids. As your listeners probably know, last month was Fibroid Awareness Month, and so we are seeing just a lot of more attention paid to fibroids.
Absolutely, and we think this is so important. Women should pay attention to this every month, particularly when they have their monthly. But of course, again, I can't say this too many times to my audience. The most important place to go for information if you have symptoms is to your own personal physician. Before I let you go, you must tell me what your most unique, interesting, or memorable experience was that you ever had in the ladies' room.
So I would say my most memorable experience, I have two, but I'm gonna go with this one. I did have to do in vitro fertilization to conceive, and I was, and I will say it was anyway, I had to do in vitro fertilization.
Oh, what were you gonna say? Tell us.
It was my janky ex-husband's sperm, but.
Oh, we are all about dumping on ex-husbands in the ladies' room. That is like our number 2 topic. Our first topic is talking about anything embarrassing or anything about sex, and then anything about janky ex-husbands.
So we did have to do IVF, and I'm happy I did it because I'm my wonderful son. But it was my first time that I was having to do the injections, and I was at dinner with girlfriends. Completely forgot that I had to do this, but thank goodness I had all my medications with me. So I'm in the ladies' room in this very small bathroom in this little restaurant, and I have all of these vials of medicine and needles and syringes, and a little old lady walked out of the bathroom stall, and I really think she thought I was doing drugs in the bathroom. And I really wanted to redeem myself and say, no. I mean, these are drugs, but not those kind of drugs.
There's just kind of no way to walk yourself out of that situation.
No.
But anyway, that's great that it worked. Of course, we're joking about your husband's sperm.
Yes.
So that gives me a opportunity to do a public service announcement about infertility. We always think about infertility as a woman's issue, but it is a couple's issue. And we usually say 40% of infertility, or 30 to 40% is because of female factors. 30 to 40% of the time it's because of male factors. And the rest of the time it's either a combination or unknown. So next time we'll have you back and we'll talk about infertility.
Yes. But thank you for highlighting that.
Yeah. Well, there's currently like 17 million couples who are actively trying to conceive. I think the pandemic may have increased their odds a bit because, many times people are just not having sex at the right time of the month. And part of that is because we actively misinform high school students when we're doing health class, and we say, if you even look at a boy, you could get pregnant. And in reality, there's 5 or 6 most common days a month that you could get pregnant. That's advice if you're trying to get pregnant. That is not advice if you are trying not to get pregnant. And that's that balance beam that doctors and family planning community all walks is, we have very different advice for different kinds of issues and different things that people are trying to achieve. Anyway, and it gets back to, again, my comment on anything related to women's health, anything related to motherhood. It all depends on everything. Anyway, thank you so much for joining us in the ladies' room. We really appreciate your time and your energy. Love the story about how you couldn't have robotic surgery because you were the only one in your area who actually does robotic surgery. Reminds me of actually the woman physician who was working at the research center in Antarctica and diagnosed her own breast mass and had to actually do her own breast surgery, which, is pretty ballsy in anybody's book, and pretty talented. I can't even imagine being in that situation. But we hear about all kinds of things in the ladies' room. So thank you for joining us, and thank you to our guests, and stay tuned till next time when we have another interesting topic in the ladies' room with Dr. Donoka.
That's all we have time for today. But let's keep the conversation going on Twitter or Facebook at Dr. Donoka. Please join us next week for another episode of In the Ladies' Room with Dr. Donoka. Real conversations with real women about really intimate topics.